This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Good morning. And I wanted to thank Daryl and the committee for inviting me down here. I am truly honored to be here, and this is a really exciting event to be partnering with ANZICS to talk about something which has really become one of my babies. Along with some people from Australia and England, we have seen this thing grow from literally nothing to where it is today. I've been asked to give a talk as a kind of an overview of where we came from, where we are, and where we're going, and I'll do my best with that. I'm going to start off, hopefully. So all history lessons, if you're involved in the history, tend to be in the first person. So I'm going to apologize up front and tell this from where I was sitting, and I apologize to those who have heard it already. So this, for me, started out as a bet gone bad. I was at the University of Pittsburgh. My boss at the time was a doctor named Richard Simmons, who was a surgeon who was one of the leading surgeons of the 20th century, who hadn't been at the patient's bedside for quite some time. And we used to have some wonderful arguments because I spent almost all my time at the bedside. There was quite a gap between what he knew to be fact and what I knew to be fact about the same thing, which neither of us could both be correct about. Dick's wife had lung cancer, and he was at her bedside one day when she was hospitalized, and she developed what he quickly recognized as a hemopneumothorax, and she was dying right in front of him. So he told the nurse to get somebody up there, and they of course sent the intern up, who must have been absolutely petrified to have the chair of surgery's wife there with the chair of surgery sitting there. And so he called the resident, and eventually Dick called up his good friend Aki Grenvik. Aki is one of the founders of critical care medicine, one of the four people who really started it. He called up Aki and he said, "Aki, you've got to save my wife's life." So Aki came down from the ICU with a couple of chest tubes and some intubating equipment, and he took care of her right there and got her swept up to the ICU within minutes and saved her life, at least for the time being. She died a different hospitalization not too long after that. But in talking to Aki after the fact about his wife, Roberta, Dick said, wouldn't it be nice if you didn't have to be the chairman of surgery's wife in order to get this kind of service? And so they put together a team which they called Condition C. Nobody knows why they chose C. Condition A was for cardiac arrest. Why didn't they choose B? I have no idea. But they called it a Condition C, which worked out well later on, and I'll come back to that. And this was a system for getting people into the ICU. So all right, I want this person to go to ICU, you sort of did it. If you wanted the person to go to the ICU 15 minutes ago, you'd call a Condition C, and the ICU would send out a team to sort of pull the patient up to the ICU. This was a system that Ronaldo Bellomo, who I think you all know, trained in at the University of Pittsburgh when he was there. So sometime after that, I was working with Dick. He asked me to be in charge of cardiac arrests, and so I worked diligently for a couple of years and got it all organized so that it was really humming. Nurses on the floors would defibrillate before the team even got there. I was really proud of this team. So I went to my boss, to Dick, one day, and I said, "Dick, I'm done with this. It's already perfect. I need something new." And he said, "What do you mean? There was a cardiac arrest this morning." And I said, "I know, I was there." He says, "Well, tell me about it." I said, "It was perfect." He goes, "We got there, the pads are already on the patient. They shocked the patient pretty much as soon as I got through him. I was there inside of 90 seconds, and it just hummed. It was great." Dick says, "What happened to the patient?" I said, "Patient died." He said, "You're an idiot." True. He said, "You're an idiot." And he said, the job is not to make the cardiac arrest look pretty. The job is to make cardiac arrest not happen. So being the brilliant intensivist that I was, I said, "You can't do that. Cardiac arrests just happen." And so we had this fight, and eventually we made the bet, as to whether they were preventable or not. And so I started reviewing charts, and within 4 charts, literally 4 charts, I knew he was right. 3 of the 4 were easily recognizable as a person who was going to have cardiac arrest. So we started working on trying to prevent the cardiac arrest from happening in the first place, and came up with our condition C. We modified it, where we would identify patients who were in distress, get a team down to deal with the problem there, and amazingly we found that about 1 in 4 needed to go to the ICU. The rest of them, if we just minded our P's and Q's, they would be just fine. So we very proudly reported this and found, to our chagrin, we weren't the first. We were not even the second, because we were outdone by the, of course, Aussies, with the likes of Ken Hillman and Ronaldo Bellomo, and a variety of their colleagues here had already put into a system which they called MET, and I believe that you know this. Similarly, in the United Kingdom, they had started out from the same place but chose a different route. They went to a critical care outreach team, which was nurses who would go look at high-risk patients, basically patients who the nurses on the floor felt uncomfortable about, patients on the floor who had been recently discharged from the intensive treatment unit. And so that, and all of these things were happening in the to late 1990s. When I finally met Ken, I already knew Ronaldo. When I finally met Ken at a conference in Brussels, we decided that we needed to pull together the few people who were working on this to learn what we knew and what we didn't know, and find areas for agreement and controversy. And so we held this conference, which was not unlike this one, except that we pulled all the faculty and stuck them in a room together for 2 days and said, all right, let's teach each other and find out what we know and we don't know. And after quite a bit of conversation, and it didn't happen until the very end of the 2 days, that we realized that there were certain things that we had all done in common. We all had a team, and we actually all thought that the team was the thing. And what we learned was the team was only one piece of the thing. And the thing was a system. The system was finding the patients, getting treatments to them, finding what caused the patients to deteriorate, and what caused, and then something to coordinate and oversee. And we called it the care and feeding of your pet, but it was the whole system. So we had this meeting. There were 475 people from 14 countries, which really surprised us. We had no idea that there would be a global reach. And so this is the system that we found, which had an afferent limb, an efferent limb. Basically, patient gets sick, you find them, you tell somebody, and then they come and fix it. And some kind of data collection to track what you're doing and why this stuff is happening, and somebody to oversee and feed it. And I think this worked very well for us, because even then we did not understand what we were doing. And we've been working inside this model for quite some time. We then, a couple of years later, held a conference because we realized pretty quickly, once you have a way to respond, the limiting factor is not, are we going to do a good job when we get there? It's how are we going to know that we need to get there? And I think there's been a lot of focus and a lot of controversy on the afferent limb that has gone into basically 2 various channels, which I'm going to talk about later on. One is the detection of it happening, and the second is the prediction of who it's going to happen to. And I have some very strong feelings about this, but I'll suffice it to say that if you have objective criteria along with a nurse worried or a physician worried or a family worried, if you put that in, you will catch most patients, somewhere in the 85% of all the patients who are at risk. And there's been a variety of methods of doing that, which I don't want to get to in this lecture, but I'll talk more about in the monitoring session that's later. Then you have the responders, and there's been a fair amount of work on this, and the thing that I'm pretty convinced about is that it doesn't matter who you send, as long as you send somebody who knows what she's doing. And it can be, systems have gone from the home team becomes the rapid responders if they're trained well enough, through PAs, nursing assistants, nurse anesthetists, a senior registrar, a fellow, critical care attending, hospitalist attending. The results are really the same. If you get people who know what they're doing there in time, everything's going to be just fine. And so I think this is going to be a kind of a closed case that just sends somebody who's smart and trained, and you'll be fine. And we've really want to make sure that the responders know what to do. There have been a lot of people who have been focusing on, and for good reason, recognizing the so-called MET syndromes. There's been a fair amount of research and reporting on the typical MET syndromes. Some are as expected, some are expected but are unexpectedly rare. For example, pulmonary embolus, I know when I was trained, caused every deterioration. It turns out it causes perhaps close to none. But the things that the people need to know really are, how do we work as a team? You have a team that's there already at the bedside, and you're bringing in these people to rescue. How do you get those teams to work well together? How do you prevent the conflict that naturally occurs when people think they're doing a good job and you bring in someone else to do the job for them? And so you have to teach intra-team work and inter-team work. And I think the most helpful thing that we learned at Pittsburgh was the first thing that the responding team needs to say is, thank you for calling, how can we help you? Because it sort of sorts out the why you're there, and it leaves people in charge who want to be in charge. What often happens is they say, fix it for me. But sometimes they don't, and this helps work around this. I think the surprising thing that has emerged, maybe it's not so surprising, in the past couple of years is a sense of professionalism amongst people who are doing predominantly MET or rapid response system work. I think the first time I heard somebody say, I'm a rapid response nurse, rapid response system nurse, was 2 or 3 years ago, where people are recognizing, I'm not a critical care nurse, I'm not a floor nurse, not emergency room, I'm a rapid response nurse. And this sense of and also for physicians doing the same thing, the sense of we are a something is emerging. And I think there's a skill set associated with coming to rescues that's different from the skill set of working either on the floor or in the ICU. So they need to understand the professionalism. They need to understand that they're not just there to rescue the patient. There are many customers at the event. So if you think of yourself as somebody who's merchandising as you respond, you've got at least 3 customers that when you get there. One is the healthcare team that's working there. You need to make them happy. One is the patient. Of course, you want to make the patient happy. And the third is you want to make the patient's family happy. And so working on that level, I'm here to help all 3 of these people be happy is important. Knowing who to bring to the ICU and who not to is something that responders need to know. You need to recognize the most common causes. Notice that of the 6 things that I put on this slide, the 5th is how do you take care of the problem? I think the fancy part are these other pieces. And then how to get help. So when I respond to an event, I need to recognize that I'm in need of another rapid response team. And knowing where my resources are is a very important fallback for me. We invented all sorts of rapid response teams at Pitt to help the helpers, and I'll come back to that. People need to know where you're going with this. We've identified at least 3 different levels of education that have to be undertaken. One is for the responders. They need to know what to expect, and they need to know the 3 customer model. And they need to work in a way that supports rather than undercuts the people who are there. And in particular, they're learning. It's the teach a person to fish rather than give them a fish model. And all of these events are events that have gotten out of control on the floor, and helping people recognize how it went out of control without them feeling guilty for it is a very important skill set. And I think although there's a lot of concern about people losing skills on the floors because they're being rescued, I think there's now pretty good data that the skills weren't there in the first place. And having a response team go there is a brilliant opportunity for education that should not be squandered. The nurses and physicians at the bedside all feel very badly about a patient deteriorating. That's not why they got up that morning. They got up the morning to help, and they were outclassed by whatever was happening. Some of these things are in their control, sometimes out of their control. But if you get them right, they're in a very receptive mode. And most people who get up in the morning to help people want to learn how to help them better tomorrow. And you can capitalize on this. And we've found that you can dramatically improve the quality of care on the floors just by turning each event into a small educational session. The second piece of education is it's not about the professionals who are responding. You need to make sure that the patient is taken care of, and concerns that this deteriorating event, if you rescue the caregivers aren't going to learn. I'm sorry, but who cares? What we're there for as a profession, as a healthcare profession, is to make sure that the patient does as well as possible. And if it hurts a couple of egos, tough. If it makes somebody's educational process a little bit worse, tough. Now, I don't think it has to go that way. I think you can help the patient and help the educational process. And if you teach people to do that, it will happen. But even if it doesn't, it's about the patient, and we have to be very, very careful not to forget that, and it's really easy to forget that. Gary Smith took the model that we had created, which is a structural model, and turned it into an organizational model that was more about the chain. First this thing happens, and the second thing happens, and the third thing happens. And I think this was a brilliant transition for me, and it helps us understand the linkage here. If you don't do all of these things, then it's not going to work. If people don't know when to call, they won't call. If people don't know what number to dial, they'll dial the wrong number. And if the nurses at the bedside aren't doing their monitoring the way they ought to, the patients will never be discovered, and so on. You could read the slide. This is one of the three educational processes we talked about. One was teaching the responders. The second one is teaching the callers how to call and recognize. And the third is just the structural components of the code. What's on the code card, who's going to arrive, when they're going to arrive, how they're going to get there. And so that is all part of this chain of prevention. If people don't know where to turn and how to recognize, it's all going to break down. I'm not sure what the weakest link is, and I think it changes with time. I think 10 years ago, all the links were broken. Now I think we're pretty good at the response team. I think education is really getting better. And I think that the gaps are in the middle. There's a lot of work being done on helping people recognize a crisis and when exactly to call for help. I think monitoring is going to be an enduring problem, and I'm going to come back to that in a little bit later. So we now have a society. I guess that officially makes us a profession. We had our international conference for a number of years on a number of continents, and over the past, I guess, 4 or 5, we decided that we really need to get together as a profession. And this corresponded with the same time that we're hearing from people that I'm a rapid response whatever, or I'm a medical emergency team system whatever. And so we created an organization to try to give those people a home and an opportunity to convene and converse with each other, to learn from each other. This is a brand new field. Even though it's been in place in Australia for quite some time, it's still brand new. We don't know exactly what the most important pieces are, but we are learning that. We had a second conference that was focused on the afferent limb that was published in Resuscitation. And I refer you all to it. Some of this stuff I'm going to be saying later on, it comes from that. It has to do with monitoring. And I'm proud to say that we had our first meeting in 2014 where we decided to have the society, and our first meeting being a society was earlier this year in Amsterdam. So far, we have over 70 members. After you guys all sign up, we'll have closer to 200. It's not expensive. We want you to do it. And they come from 12 countries, which is remarkable for societies that's been accepting members since April. So I think we're really proud of the scope and reach, and we're hoping that having this group together will help forward what we have learned about rapid response and how to move it forward. Publications were initially very hard. People just weren't interested in this. There was no intervention in how most medical journals understood interventions. I have to give great credit to Ronaldo and Ken and their groups and the Medical Journal of Australia for publishing stuff that there was no home for. Resuscitation has recently put out a call for papers. The Joint Commission Journal for Quality and Patient Safety has had a column for now 9 years devoted to rapid response systems that has had every month there's some article in it. So there's starting to be some pretty good places. In fact, it's hard to open a journal anymore that has some critical care aspect to it, whether it's nursing or in medicine, that doesn't have something about rapid response systems in it. And so I think the opportunities are very broad for those of you who want to publish, which is quite nice. We don't have our own dedicated journal, and I think that's fine by me because this is something that spans all of healthcare. It's fine for it to reside in each of these different fields. So the current issues are, do they work? And I think this is going to continue to be a problem, and I'll describe why in just a moment. But I believe that this question has been answered. This is data that was recently published out of Australia by Jack Chen, looking at the relationship between the uptake of rapid response systems in terms of the percentage of hospitals that have a rapid response system and all-cause hospital mortality, and looking at the cardiac arrest rate and the response to cardiac arrest. And so in the bottom panel here, you have this is the percent uptake in hospitals. That's this line here, and you can see Australia is probably, in terms of a rapid response system, the world leader in terms of the percentage of hospitals which have taken on a rapid response system. And this here is all-cause hospital mortality dropping from 18 down to 14. And this is the cardiac arrest rate down here in hospital cardiac arrest, and this is the mortality. And you can see this drop in all-cause hospital mortality is not due to improved response to cardiac arrest. The improvement is from the decrease in the number of cardiac arrests. And I think this really, in my mind, puts the nail in the coffin of do they work. It kind of doesn't matter what aspect of it works, but having a system in place seems to matter a lot. The second is the need for physiological monitoring. And I'll say that I have a very strong bias about this. And I'm not alone, but I'm not in the majority, I think. David Bates and E.L. Zimmerman both have a lot of work in advanced continuous physiological monitoring systems. And they have opined, and I agree with this, that the next step is to get every patient in every hospital in every country in the world to have continuous physiological monitoring. And the problem is that you can't predict the future. Models which use severity of illness to try to figure out who is going to have the cardiac arrest now and prevent it is just, it's just in a sense a card game or a parlor trick. We can get good at it, but we're never going to get good enough that we can reach our goal, which is no cardiac arrests in hospitals. There should be no unplanned deaths in hospital. This was the second thing that Dick Simmons told me after he said, "You're an idiot." That was correct. The second thing was nobody should die in hospital unless it's okay for that person to die. Meaning we need to not only advance our ability to prevent cardiac arrest, we need to identify those who are going to die from their illness and make sure that it happens as well as possible. And if you don't identify those patients up front, as well as the ones that you want to save, you're not going to be able to take care of them well either. So Gary Smith and his colleagues put together a number of studies looking at a gigantic database of vital signs and the probability of death. And they got an area under the curve that's 0.782, which is pretty good. They have revised this. They're up into the mid 0.83, 0.84. They're doing very well in terms of their predictive capability. So they can find most of the patients who are going to have demise within the next 2 to 24 hours. The problem is not the area under the curve. The problem is the area over the curve. These are the people who are not identified by the model and still have an in-hospital cardiac arrest. This cannot go away with the predictive model. It cannot. Any more than you can predict who's going to win a horse race or who's going to win the football game. We simply don't know the future. There's too many things that can happen that you can't predict, like John getting Mary's medicine, or Ted having a first-time ever reaction to a medicine that has not been taken before. Things happen in transport that we haven't identified. The risk of going to radiology for a study increases your in-hospital mortality by 4 times. Just the trip there. Doesn't matter what study you do. So you're not going to predict this. Right? This model is based on vital signs and some laboratory data, and does not reflect who's going to get monitored and who's going to be left in the hallway while somebody's checking something out and they forget to hook up the oxygen. So I believe that predictive models, they're great. They really help you with triage, but they're not going to help you get that final 5 yards to the goal line. So there have been a number of studies. EAL put one together using an in-bed monitor of respiratory rate and heart rate. This is by Andreas Tanzer, who did a very nice study using continuous pulse oximetry before and after trial in 3 units. In one of the 3 units, he put continuous pulse ox on patients who wouldn't normally have pulse ox on them anyway. And he found that there was a dramatic decrease in, let's see, there it is, a dramatic decrease in the in-hospital crisis events that was not replicated in the 2 control units. And this is the number of patients sent to the ICU, I believe. So just the continuous monitoring helped identify patients faster. We ran a similar study at our hospital where we monitored 4 different vital signs and had continuous monitoring in a step-down unit. These are patients who are predicted to be high risk, and 75% of the patients on that unit never had a single abnormal vital sign in hundreds of thousands of hours of monitoring. Maybe it was dollars. And of the 25% that had an abnormality, 80% of those only had 1 abnormal vital sign. There were no deaths on that unit at all in 3 years, except for 2 patients who were to be discharged the following day. And the nurse and the patient said, "I'm not sleeping well." They took the monitoring off, and both patients were found dead in bed by the next morning. So I am firmly convinced that knowing what's happening with each of your patients at all times is essential if you're going to prevent all of them, as opposed to most of them. So I think the focus of rapid response systems has been on the deteriorating patient, people who have wildly abnormal vital signs. But this application has spread out over other forms of in-hospital problems that need you to fix them right now. And I have a couple examples. One was set up in our women's hospital at Pittsburgh. This has been copied at a number of organizations now, where they actually have a team response to an obstetric emergency. This has been very helpful in reducing infant mortality and maternal mortality. We had a problem at one of our hospitals where the patient's family was very concerned that the patient was dying, and nobody listened. And this was, of course, what happened with Josie King at Johns Hopkins. It also happened to a woman named Helen Haskell, who has become affiliated with our organization. Her son Ryan died while she watched and was begging for help. Robert Wood Johnson Foundation has now gotten on board for a condition HELP, which is allowing family activation of the rapid response system. I think this is here to stay and is a very good thing. The way we handled site crises was you call security, they pin the patient down, you give them some ketamine or other tranquilizer, and it makes everything better. We put in place a system where instead we called a psychiatrist and a psych liaison nurse to come to basically talk the patient down off the bed or the walls or out of the middle of the hallway or take things out of their hands. And we found that the use of force and sedation went down just by bringing the right people in to handle the crisis at the right time. And I'll let you look at the rest of these. And you can see that these are all crises because you don't have what you need in place at the time that you need them. Hospitals are not high reliability organizations. They have death rates that are on the order of some single-digit number per 1,000. And in order to be a high reliability organization, you need to have error events in the order of 1 per 100,000, 1 per million. We're 1,000 times weaker than a high reliability organization. This isn't just United States, this is worldwide. In order to become a HRO, you have to have both a recovery from when patients go bad and a prevention system to keep things from going bad in the first place. And this results in the need for 80% fixes. You keep fixing 80%. And it's interesting that the predictive model fixes 80%. You can find 80%. We need to now take 80% of the remaining 80% and so on. And I think we will get there, but it's a long road between where we are now and where we need to be. RRSs are now implemented pretty much worldwide. I haven't seen a report out of Africa yet, but out of every other continent that they exist. And they're becoming really commonplace in as long as Australia, Western Pacific Rim, Northern Europe, and America, you're doing pretty good. This is a culture change. This is very different from the way we all learned the healthcare profession. And I know I'm going over just a little bit, if you bear with me for just a few minutes. Culture change always causes pushback. This was a study that was recently published that I think is very important. It's a really very large study of looking at the impact on the healthcare professionals of having a rapid response system in place. And you can see that the numbers of interviews and questionnaires that put out to get a almost 70% response rate is really hard to do. I mean, you really have to work the field very well in order to get that. And they found that in 1,000 MET attendees, there were 214 incidents of interrupted care, which put at 1 incident for every MET team called. And 99.5% of those, interestingly, were, you interrupted my rounds. There were no adverse patient consequences from those. The conclusion was METs disrupt the healthcare professional's day. And my answer is, go back to that slide I had about 15 slides ago. It's not about you. It's about the patient. And if you have an intervention that causes an inconvenience for the healthcare professionals but saves lives, to me that's a slam dunk decision for those of you who follow basketball. And I think we need to be aware that, yes, we are inconveniencing the healthcare professionals. We have to attend to them, but that doesn't mean the system's a bad system. We need to work on making it work better. And the reason it's causing chatter is it's a disruptive technology. Disruptive technologies are things which come in kind of quietly and then get rid of everything that was before them. Think mobile telephones. How many people in this room still have landlines? In the United States, 40% of Americans have gone away from having landlines because of this personal mobile system that they have. And there's a number of examples you could see. Rapid response system is definitely a disruptive technology. It is going to cause changes in the entire healthcare system. It's going to take a decade or two, but it is going to reformulate how healthcare is delivered. It has to, because we have to become a high reliability organization. You can't be a high reliability organization without a rapid response system of some sort. I'll skip over that. So where are we headed? There is no question in my mind that we are going to go to continuous monitoring for every patient in the hospital. You can't discriminate who are the highest risk patients, who aren't. 1/3 of these events occur in patients who are too healthy to need monitoring. Just the numbers are there. We have to go there. The question is, how do you do it without disrupting too much? And then we need to make sure that we are using rapid response systems in other novel ways that we have yet to discover. We need to look at why these events occur and fix them beforehand, and we need to find the money to do it. I think ultimately the patients are going to be a driver. How many people in this room are wearing a Fitbit right now? Is anybody wearing Fitbits? Raise your hand. Really high. So imagine you go into the hospital and they don't put a monitor on you, and your Fitbit is showing that you're deteriorating. The use of Fitbit is expanding exponentially. Right now, 1 in 10 patients have it in the US. It's going to be 50% pretty soon. Imagine what's going to happen to the hospital if the patient's monitoring system is better than the hospital's monitoring system. This is going to be a change, and I think we should take advantage of this, find out ways to incorporate systems of monitoring that are going to help us find these patients and respond better. And with that, I'll end. Thank you very much.